Hello, everyone. Again, thank you for being here this afternoon today for MassBio's Make Shift Happen program, where we discuss anything and everything related to inclusion, diversity, and engagement and equity. And for the month of September, it is powered by Foundation Medicine. I cannot thank them enough, not just for their support, not just for their commitment to ED&I, but for everything that they do for cancer research. But before we get started, I would like to go over the ground rules with you. For the first 20 minutes or so, it's going to be a Q&A with the guest and I, and please feel free to raise your hands in regards to chat in the Q&A. And then after those 20 minutes, we're going to open it up to the audience to ask questions. So the program is about 40 to 45 minutes, and now let's get started. September, again, is National Awareness Month for prostate, childhood, ovarian cancer, blood, leukemia, and lymphoma and thyroid cancer. I would like to introduce you to a couple of people who may possibly know a thing or two about the subject matter. Today, joining us from Dana-Farber Cancer Institute will be Dr. Tim Rebbeck, Director of Cancer Equity and Engagement, and Ildemaro Gonzalez, Vice President and Chief Inclusion and Diversity Officer at the Dana-Farber Cancer Institute. Thank you both for joining us.
Thank you. Great to be here.
Awesome. Well, Tim, if you don't mind, I'm going to start with questions for you first. How is Dana-Farber addressing the cancer burden on Massachusetts residents, including research, clinical trials, community outreach, and anything along those lines?
Well, Dana-Farber has taken a very proactive view about the needs of the cancer burden in underserved populations. These can include poorly resourced individuals, those with inadequate access to care and prevention, minority groups, racial, ethnic, gender minority groups. And we've really put together a comprehensive package to begin to look at these issues, first by defining what we think the problems might be in Massachusetts, which is our catchment area. And we do that by looking at statistics and data, but we also engage the community to get through focus groups or other kinds of discussion what the community sees as the problem. And we also then bring in the researcher. And so we have a group of different individuals, researchers, community groups, people who understand the statistical burden of cancer, and we bring them all together, and we've created a report or a strategic plan, essentially, of what we think are the leading cancers that need to be addressed. And so we've identified a few that include things like liver cancer, and breast cancer, prostate cancer, which are important cancers from a mortality standpoint and or are growing in incidence and mortality. They're going to be, the problem is increasing. The other thing that we've really addressed recently is participation in clinical research, participation in clinical trials. What we found is that individuals who are underserved minority populations tend not to be included in clinical trials for a number of reasons. This can be because they don't have access to the centers that have those clinical trials ongoing. It can be that they are excluded from clinical trials because they tend to have more comorbidities or other conditions that might lead them to not be eligible for a clinical trial. And they also, even if they do have access or are eligible, just don't often make it into the system. They don't get asked to be part of clinical trials. They don't know to ask about clinical trials. So we're trying to take a really broad view of getting individuals into research, into participating in research, and making sure that the research that we generate includes diverse populations, so that the results of that research will be relevant to all populations, not just people with insurance or the majority in the population. I could go on and on, but you can ask me more questions.
Well, I want to actually, in regards to comorbidities, access to clinical trials, I saw that Dana-Farber is actively supporting a bill right now that's pending in front of the Commonwealth, the H4211. Do you mind going a little bit into that and how it can also affect the patient community as well as the biopharma industry?
Yeah, so one of the issues with participation in clinical trials, particularly for underserved populations, is that they may need help and support in being able to participate in a clinical trial. So you can imagine someone who is under-resourced may not be able to drive in. They might need a Uber to get in. They might need childcare, or they might need to be able to take time off work. And particularly if they're in an intense clinical trial, that might be a lot of days off work. And so people that are have limited resources are less able to do those kinds of, manage those sorts of things. So this House bill in Massachusetts is addressing the problem that many have observed, that clinical trials do not allow people to receive that kind of support because it's considered inducement. That is, if you are given money to participate in a clinical trial, then are you being induced inappropriately, not coerced, but induced to participate where you might otherwise not? And so there's this burden on underserved populations because they may not have the funds to participate, or the time, or the resources. Yet if we give it to them, many consider that to be an illegal inducement for participation. So this House bill is really just to say, we're not inducing people, we're not forcing the people to be on clinical trials because we're going to pay for their childcare. We're allowing them to participate, and to make sure that it's clear to the law that we're not, inappropriately having some populations participate in clinical trials because they'll get money from it. So that's what this House bill is doing. It's actually moved quite far forward. A number of states have already passed this bill. Massachusetts is not, but it has moved far forward, and we hope this fall it will be passed.
I'm speechless right now because I can't believe that there would be a bill standing in the way of people from diverse populations to participate in this clinical
bill
trial.
is to help them participate. The
Yeah.
way it is, people are rejected from participating in trials because they can't afford to participate. That only hurts the underserved, the minority, the populations that are low income, et cetera. And the fact that we even need a bill to show that, to demonstrate that, is really a symptom of the larger problem of getting underserved populations into clinical care, into clinical research, et cetera. It tells you the depth of the problem we're facing.
It's a term from the South Side of Chicago we have to describe this, but I'm just going to ask, if you don't mind, who is the leading forces or driving forces behind this bill? Because it's counteractive to what we're trying to do in biopharma right now.
Absolutely. So
not the bill, but
Right, yes, exactly. And that's what many of us recognize, the important need for these kinds of policy changes. So Hannah Kane is a state representative who's the sponsor of this bill, and it's being supported by Dana-Farber. Lori Glimpsher has met with and corresponded with many of the leaders in Beacon Hill to make this happen, and the Lazarex Foundation, which is a large foundation dealing with access to research and clinical trials, has been supporting this across the country. So it's something that's been going forward. Again, it's finally made it to the point where it's off the table. It was actually tabled for a couple of years. It's now back on the table and going to be discussed this fall.
Well, thank you for bringing this to light, because I think that this is taking away from having to even have this bill sponsored. It takes away from so many other things that we need to be sponsored and things to be doing. And it's counteractive of what we're trying to do in the biopharma industry. But we're going to stay abreast of this, and please keep us up to date with any developments and how we can help support moving this along. So let's continue with the discussion that we have on hand, because we can't solve all the political issues that we have within 20 or 30 minutes. So if you can give us an idea and shed some light on what the Center for Cancer Equity and Engagement is doing. From my understanding, a significant component is to improve minority access to the clinical trials. So aside from sponsoring this bill, what else is the center doing?
Yeah, well, many things. I think the overarching philosophy is that the Dana-Farber Harvard Cancer Center, the Harvard institutions, Dana-Farber Cancer Institute, are research institutions. We have a huge amount of research that's relevant to developing new therapies, to implementation science, to finding out risk factors, figuring out how to get people to benefit from cancer discoveries. And so our center's really goal is to figure out how to make sure those discoveries make it to the populations that can benefit. So as you know, a lot of research ends up being written up into nice papers, People give talks, and then the research dies. We kind of call this bench to bookshelf science. It's great work, it's great discoveries, but it doesn't usually impact on the people out in the population that need it. So one of our jobs is to ensure that we can translate and deliver the research, disseminate, implement the research in populations. So that is a couple of issues associated with it. First of all, we have to identify what research might be able to be pushed out into populations. Maybe there needs to be research to figure out how it would work in a community health center or in a general hospital. We need to make sure that the research is done in a way that it will be beneficial to diverse populations, minority populations. As you know, in many types of research, the majority white populations are the major ones that are included. And we know from a lot of work that those populations don't represent all of the constituency who will benefit. But when we don't include diverse populations, we make mistakes. We make errors in terms of determining what a genomic risk factor is. We don't do the research well for all populations. And so our goal is to really make sure all populations benefit. So that can be, as you said, access to care, but it also could be translation of the research. It could be making the research more diverse. It could be, and it does include making sure that the community's voice is heard so that when we do our research, we know what the community needs. So that our center is really a nodal point for getting all of those conversations to happen.
Okay, well, where do you think we can address some of the bias in this? Is it publication bias? Is it sometimes something we're doing in regards to sponsor or site bias? Where can we eradicate or attack some of this?
So a lot of the issue deals with the populations that are seen in many of our major research centers. So Dana-Farber, for example, sees a very white, insured kind of population. And that's fine. And Ildemaro will probably talk in a moment about our interest in including more diverse populations in the clinical space. But what we really need to do is make sure our research goes out to Boston Medical Center, community health centers, St. Elizabeth's Hospital, DIMIC, places where underserved populations, minority populations are seen, because they're not all coming to Dana-Farber. They're not all coming to Mass General. They need to come. We need to make sure that we reach out to them and we make sure that our research is accessible to them. So it's very doable. And so we've begun to develop partnerships, for example, with Boston Medical Center, which is the large safety net hospital where a large proportion of racial and ethnic minority patients are seen for cancer, and to make sure that our clinical trials, our clinical research is actually accessible to the patients that are seen there, but don't necessarily come to Dana-Farber. So, I mean, there's a lot of examples of that, but that's one in which we can begin to reach out to patients and or bring them back into Dana-Farber so that they are actually participating.
Okay, great. Well, let's transition to Ildemaro. If you don't mind picking up where Tim just left off in regards to the relationship with safety net hospitals and getting more access, treatment, diagnostics, testing, treatment to the safety net hospitals and working better with clinical trials. That'd be great if you could elaborate on that.
You're muted.
Can everyone hear me now?
Yes, we can. Thank you.
So when we talk about our efforts in inclusion, diversity, and equity at Dana-Farber, what we discuss is all aspects of everything we do. So from the research, and Tim has done a great job, and how we benefit from centers and the DFHCC partnership, but also our clinical care and our talent and our community, which is a little bit more common. So we find, for example, that as Tim was saying, we need to actually do a little bit more in attracting minority patients to it. So whether that is physically attracting them to our facilities, or as we have discussed, partnering with different institutions to expand the care there. That is part of our actions around it. Specifically, when we look at attracting patients, we do a couple of things. We understand first our satisfaction, because as any business, right, you want do you have repeat customers? Do they feel that they belong with your brand or with your institution? So for us, trying to understand what that satisfaction scores and what those satisfaction scores look like between minority versus non-minority patients is important, because it tells us what in the experience we can improve. What for, and they differ, and why patients are having tell us they have a better experience with us. So with that information in hand, we then start implementing not just informational campaigns, but what is it in the insurance? What is it in, do we have insurance barriers? Do we have actually a perception barrier of maybe historic incidents that are now preventing individuals from coming here? And that's the kind of initiatives that we're putting in place.
Do you think that, well, let's transition from, we're talking about getting more people involved in clinical trials. Do you think it will help if we have more people, or if we have some type of effort to diversify the oncology workforce to get more people from different backgrounds to participate in them?
Is diversifying the workforce, will it impact participation in minority participation in trials? I think absolutely. The answer is yes. Not only it will help diversify the trials, but it'll ultimately impact patient outcomes, right? So in diversifying the workforce, why does it matter? There is a lot of and Tim spoke to a couple of aspects as perhaps why individuals don't come, right? Do we have the right trials that the community needs? Is it a level of trial that is actually, breast, prostate, things that the community need, or is it such bench trial that it's less popular? That's one. For us, most importantly, is when you diversify the workforce, and why do we do this? We do this because it impacts patients. Simply put, that's why a diverse workforce impacts patient outcomes. And in a way of this, and perhaps as early as 2000, there was some research there called around the Diversity in Health Professions, a Review of Evidence. I like to quote that because that study actually put in evidence a couple of things. One, that minority professionals tend to practice and disproportionately practice where minorities and underserved populations are seen. Two, that minority patients tend to receive better interpersonal care. Why? Because there is a concordance there of lived experience. And three, again, when there are LEP patients, limited English proficiency patients, so when language is concordant, when we speak the same language, also they get a better experience, and patients tend to have greater medical comprehension, greater likelihood of coming back. So if aspects that prevent people from participating in trials are of trust, because intergenerational trauma that, we've all heard the stories in Tuskegee and all of those, aspects of that kind of perception in the medicine field can be mitigated by a provider or a physician that actually have a shared lived experience that can understand where you're coming from. So does it impact? Yes. What are we doing about it, right? What are we doing to diversify our workforce? And I want to say that this is one area that we recognize as many of our peer organizations, that there's a lot to do around this to get to the place, right? Right about 5% or so of oncologists are Hispanic, 6% African American. The numbers are slow. For us, this starts early on in high school. So through our workforce development programs, we have for years now, for probably 12 years now, we have a program with our local high schools here in Boston that bring ninth graders all the way through graduate level individuals to be exposed to careers in healthcare, to be exposed through our CURE program, part of also the EFHCC, to research environments, through our pre-matriculation program with HMS, the medical school at Harvard. We also host admitted, but prior to starting class, admitted first-year students. We host them here to, again, expose them not only to medicine, but specifically oncology. All of these programs focused on minority individuals and underserved individuals. Now, does taking care of the early pipeline solve the what am I doing around faculty right now, where there are many aspects there that we're still trying to solve for? A part of it is, is disparities research feel that a lot of minority faculty tend to favor in their focus. Is disparities research equally valuable for a promotion track than bench research and so on? So these are the aspects that we're still trying to uncover.
Well, we're talking about what's taking place in some of our Black and Brown communities. And we would be remiss if we didn't talk about how September 15th through October 15th marks National Hispanic Heritage Month. So I would like to know, what does that mean to Dana-Farber? And also, what does that mean to you when you're part of the Hispanic community?
So let me start with what does it mean for me, right?
Okay.
And personally, just represents a time of the year to highlight, to recognize, to write into history the contributions of the Hispanic Latinos, towards this nation, right? That's one. So that for one reason or another, they may be left out of the common knowledge, right? Just like we do in Black History Month and others. It's also a time to help balance this perception that the communities have, or the audience in general have, right? With more positive associations. So this is when you actually tell individuals, hey, did you know perhaps this leader and this inventor and this individual is of Hispanic origin, so that you start associating also with the community or the race and ethnicity with positive outcomes. For me, in short, it's 1/3 recognizing the individual and their contributions, 1/3 ensuring that the younger generation understand how members of the race have contributed to our nation's success, and thirdly, and consequently, the last third here, it's inspiring those in the community to keep working hard, to keep at it, because they too have a valuable role to play. It is very often that, I don't want to say very often, but I hear from some of my Hispanic friends and colleagues, when I invite them to a panel or to something, they always tell me, I don't know if I should be in your panel, because everything that I have achieved, I achieved it through my efforts, through those of my family, not because of a special concession that for being Hispanic. So should I really be highlighted? And I always tell individuals, don't do it for you. This is actually for that child that is sitting somewhere watching their parents, work hard, and hearing their parents say you can be anything you want to be, but not having a doctor, an administrator, a physician, a nurse in their network. So it's really that aspect of inspiring people. What do we specifically do? This vision perhaps helps us mark what we do at the Institute. Also, Mosaic, our employee resource group, oversees our celebrations here and recognition. And what we do, we recognize community organizations that advance, again, the Hispanic and Latino cause. Through online marketing, we highlight, yes, historical figures, but I think equally important, current employees and their impact. But I like to think, quite frankly, that we celebrate Hispanic Heritage Month, for example, when every day we host our patient support groups for Spanish-speaking patients, when we move our language interpretation services from interpreters to actually being cultural brokers and advocates. So for us, I think it's a celebration. It's a year-round celebration. During COVID, it looks a little bit different, I have to say.
Well, this is great. So what we're going to do right now is open up the mics, audio, video for our guests and for the audience to ask questions of both Tim and Ildemaro. And in the interim, I would like to send a shout out to a couple of the MassBio member community that has made the top 100 most influential Hispanic Latinx people list that is published by the Cell Signal Technology publication, which is an Elsevier magazine that comes out. Christine Ortiz, who's with MIT, made the list, and also Grace Colon, who is with Encarta Therapeutic, made the list. They pulled the list together specifically to demonstrate this is what the scientific community looks like. This is a resource for people who say that they can't find a Hispanic Latino talent or hiring or programs to speak on panels. So if you get a chance, and I'll add it to the chat section, it's the Cell Signal Technology 100 Most Influential Hispanic Latinx in America. And this just recently came out. I want to send a shout out to our MassBio member organization employees and family that made the list. And if you get a chance, please check it out. And do we have any questions right now from the audience? Okay, Grand Challenge. Could you, Ildemaro or Tim, if you don't mind taking this question, can you tell us a little bit about the Grand Challenge that Dana-Farber is working on right now?
So we had a little question about which one you mean, because there are so many grand challenges that are out there. But there is one grand challenge that we just funded through Dana-Farber, and that is what we referred to as a minority accruals to clinical trials grand challenge. And it's a grant that is intended to understand and develop the strategies for getting underserved populations into clinical research. Sort of like what I was talking about before, this is being led by a multidisciplinary group to link the trials that we have ongoing to patients that are not in Dana-Farber. So for example, one of the issues that some of you may be aware of is that the Mass Health, the Medicaid public assistance kind of insurance that you can get, anyone can get, doesn't allow patients to come to Dana-Farber. Dana-Farber will take anybody, but your insurance that you have may limit you. And so there are issues about just access by insurance alone. How do you then get patients like that to be able to access the cutting edge trials that Dana-Farber is doing, the cutting edge science? And so part of our grand challenge is to figure out that question. We're probably not going to immediately change the funding model for insurance in Massachusetts, so we're working on that as well. But we want to make sure that under the current circumstances, how do we get people to have access? And that's this grand challenge team approach that's just been funded to sort of figure out those very hard questions. And I can go into more detail if you want, or maybe Ildemaro also knows of a different grand challenge that we're referring to.
Well, what we can do, if you get a chance, because I'm going to ask Ildemaro a question. So while I ask Ildemaro a question from the audience, Tim, if you can type into the chat section a link or a place where we can find more information about all the different grant challenges that Dana-Farber has right now.
I don't know that there is a single link, but I can take a look. They're all over the place. There's a bunch of them. So I am not sure there's a single link that shows all of them, but they are around. You can look.
Yeah, if you could. If not, what I can do is when we follow up with the attendees right now, we can send the links in our follow-up survey.
Yes, that'd be great. I can look for those for you.
Okay, awesome. So we have a question from Daniel. What is Dana-Farber personally doing as part of their own clinical trials to expand access to people of color or the Latinx communities?
Yeah, so that's a little bit of what I was discussing before. Again, some of this involves referral patterns, patients who would tend to go to Boston Medical Center or Cambridge Health Alliance or one of the other centers around the city that treats patients, but doesn't have as much clinical trial activity. How does a patient who's failed a particular therapy or might be eligible for a clinical trial, who might be minority, ethnic, racial minority, or just underserved because of access to care, to funds, to insurance, how do we navigate those people into a setting where they can get the cutting edge science and benefit from the cutting edge science? So again, part of that is making these partnerships with Boston Medical Center and other institutions, Cambridge Health Alliance, to get our trials to be opened in those centers. So that's obviously something we can do with some trials, but not others, if they don't have the resources and infrastructure at those other centers. For the phase 1 trials, for example, where there's a lot of, not everybody's going to open up a phase 1 clinical center. What we worked on is trying to get the patients to be able to come to Dana-Farber to allow them to benefit from the clinical trials that couldn't be opened in other places. So it's really a multi-tiered approach. We also have been working with access, just in terms of patient navigation. How do people get Uber or childcare or any of those other things? How do the patients understand what a clinical trial is, why they're being sent or asked to participate? So navigation, actual infrastructure or logistical support, and then the interaction between institutions to make sure people can participate in the trials when they're eligible. So lots and lots of different such things. Yeah. I don't know if that answers the question, but.
No, it does. It actually leads us to our next question. Our audience would like to know, what do you think clinical trials of the future will look like?
So I think there's a couple of things that we've been struggling with, and I'll focus it around my answer around the diversity inclusion problem, not because there's a million answers to that question depending on whether you're a clinician, a clinical trialist, that sort of thing. But I think that, one of the things that we've seen, and there's a couple of great papers that were done by a group led by Zach Doheny at Harvard that showed that if you do clinical trials and you do research, particularly genomics research, in majority populations, and you make your inferences and lead your trials to the population for actual therapeutics out there in the field, but those patients didn't include a diverse group, you make all kinds of errors. So in the genomics world, for example, there's a number of reports now where studies were done entirely in white populations, and it was inferred that some of these genomic traits that were associated with risk of disease or precision oncology response to treatment were thought to be predictive, but it's only because those of the characteristics of those genomic traits in white populations. And when they went back out and tried to do the same work in Black, Hispanic, Asian populations, they realized these are just common variants in most other populations, happen to be rare in whites. And we just made all kinds of errors in terms of treating. So I think that people are going to recognize that you don't just benefit the minority populations by making more inclusive these trials, you benefit everybody. You make fewer errors, you understand the science better, and the ability to treat patients, the ability to then take these therapeutics, take the scientific knowledge, and have it benefit all, requires that diverse populations be used in this research to begin with. It's not just the minorities that benefit. All populations benefit by doing this the right way. So in the future, people are going to understand that by not having diverse populations, your drug isn't going to work as well, you're not going to be able to use it in the same way, the populations are not going to benefit. And I think that people are going to understand the value of these kinds of approaches, not only to benefit minorities, but white majority of the populations also. So that's one way I think that we're just realizing we have to do this. There's no way around making the research diverse.
Excellent. Daniel actually thanks you, Tim, for that answer. We only have time for a couple more questions. Ildemaro, we are working on improving cultural competencies at our company. How do you think this engenders trust and comfort in patients?
So let me give you one example. We got a call from our patient services that one of our patients was in the consult, and a doctor asks why your blood pressure seems a little high, a little bit of temperature, what's impacting you? And then our patient says, it's been really all this tension, and then reading the media and the George Floyd situation, the murder of George Floyd, and all this social tensions. It's really gotten me stressed and so on. And then the doctor says, okay, but why do you really feel, in the intent, in his or her intent to really understand the root cause. So the patient felt, this physician is not understanding my life experience, is not understanding where I come from. So she came out and went to our patient and family services, and ultimately they called me. The patient, at the end of the day, her only question was, what is Dana-Farber doing to actually, enable its providers to understand the cultural differences and cultural competency and all of this. So is it important? Yes. Patients are not asking, and as with that example, you understand that patients are actually demanding it even. If you're doing it, and what are we doing for it? I would argue that every cultural competency training, cultural humility, whatever you call it, right, needs to, yes, start in the classroom perhaps. There is no silver bullet. It is more of a dexterity conversation than an ability to work with Hispanics or African Americans or so on and so forth. But taking it from the classroom to then case explorations or Schwartz round, where you actually analyze situations that happened in your services, and then ultimately a combination of also a patient panel where patients, and this is how we're setting it up, right, where patients come and discuss with our physicians and our teams, not just physicians, because everyone's part of the experience, from the person at the registration desk to the department attendant, right? What the impact of this is, and what are we talking about? We're talking about perhaps this, this triangulation technique, where if you're not getting patients to follow a treatment plan, or if you're needing some information, you seek to a person that is part of their trust, network, and then have them influence, which is there was a great practice there in diabetes report where they weren't sending in, Hispanic patients weren't sending in the data, and so they started asking everyone to bring your best friend. And then the doctors would say, you, Jose, are going to make sure Tim here sends the reports in, and they saw an increased accrual of the data. So we're talking about triangulation, understanding the role of faith. We're talking about all these nuances of individuals' background. So if you're leaving it at the classroom training, it's not enough. Make it hands-on experience with your patients' cases, and then have your patients talk to your providers, and ultimately take a look at what are the policies and practices and supporting services that enable that great experience for diverse patients, whether you call them LGBTQ, limited English proficiency, low socioeconomic status, or homeless.
Well, thank you. And this brings us to our last question for either Tim or Ildemaro. If you can ask of one thing of the biopharma industry, something we can do that we aren't doing, what would it be?
You wanna? Let me start. One of the things that I think that's been extremely limited, and in a lot of our activities in cancer, has been around cancer prevention and early detection, particularly in underserved populations. And I think that one of the things that we don't do very well is partner with industry, partner with biopharma to figure out how to make discoveries, basic scientific discoveries that we do in populations, to bring them out where they can be commercialized or marketed. And thus in a way that affects all populations. So, we don't tend to do a lot of science that is, again, it's bench to bookshelf science, but we don't know how to market. We don't know how to develop a lot of these tools, even though we have some great ideas. So if there's a way we could ever partner with industry to translate our basic research discoveries, just like you do with drug discovery, but do it in a way that really leads to prevention, early detection approaches, that would be an amazing thing for us to be able to do. It's a huge hole in our ability to make sure that these early prevention strategies can reach out into populations broadly.
Is there someone in particular that they can reach out to a Dana-Farber to assist or to follow up with this discussion?
Me?
Oh.
I do that. We're trying to do that. There's also Leslie Solomon, who is the I don't know
very well.
Yeah, Leslie, who deals with the industry relationships. But we're trying to spend a lot of time to partner with industry, partner with biotech and pharma in the way I just described. So if anybody wants to contact me with ideas, I'd love to talk with you. If you can,
if you can include your email address, the best way to contact you in the chat section.
Yep, I'm putting my email in there right now.
Okay.
Yep.
I would add to Tim's, it's perhaps a shift in mindset where it's very common for organizations to think of working with minorities is equivalent to working with underserved, poor, or so on and so forth.
Yeah.
Yes, there is a proportionality there. Statistically, we all know that. But when, at least in our work, we see it both ways. We see, yes, there's an opportunity to treat and care for the underserved, but remember, there's also a market share there. There is also a segment of the population that is a minority, that is not underserved, and is equally not having a great experience. So it's this intentional understanding of their, if you're a business and you see the profits, it's an intentional understanding of the market share that you are or may be missing out on, and yes, also funding work and doing work around underserved populations. So that would be my ask.
Well, and just to enhance what Ildemaro just said, lumping all of the other groups together, we need to do more diversity. We need to do disparities, as if the underserved minority groups, LGBTQ groups, et cetera, were all the same. We need to be more specific about what we mean, who we're trying to study, who we're trying to reach out to, and for what purpose. And I think that Ildemaro's point is very well taken. It's not all the same. Everybody's needs are not the same.
Okay, well, I'd like to thank you both for joining us. There is tremendous hope in cancer research, and let's all make sure that we are doing what we're all able to do, but also strive to be better. I would like to thank you for attending and everyone's participation and for being an ally. And for those who are interested in learning more about what Dana-Farber is doing, please feel free. I'm going to volunteer this to reach out to Ildemaro and Tim. And please don't forget to put your email addresses in the chat section. And remember, don't wait. Click on their email addresses right now so you don't forget the questions you want to ask them. I will also like to thank Foundation Medicine for their support in bringing Make Shift Happen to us for the month of September. And for our upcoming events, I'd like to continue the cancer conversation with our October 1st event around cancer. We also have both the Bob Coughlin and I holding a keynote address for the October 7th Latinos in Bio event. And for October 13th, we have the Dr. Rafael Grossman, who is the first surgeon to perform a live surgery using Google Glass, and his journey from Caracas, Venezuela to here in the United States. I would like to say thank you everyone for joining us, and I look forward to seeing you soon. Thank you.
Thank you.
Thank you.